school-based health centers, and Dr. Spencer, our infection prevention advisor. On panel will also be Ladaryl Hale from our immunization program, as well as Dr. Catherine Cunard, who is our prevention medicine advisor. So just a little bit of housekeeping. We will save about 15 minutes towards the end of the session for questions and Q&A. But if you have questions before then, you can also put them in the chat, and our panelists will try to get to them as we speak. I also want to say a huge thank you to our Illinois chapter for the American Association of Pediatrics for offering CME credits. There are also non-CME CEUs that will be offered through this program. So if you are in attendance and are requiring of CMEs, we are offering 1 AMA PRA Cat 1 credits, and the requirement for that will be that you will have to answer a question in the end. Stephanie Atella from ICAP will put the link in the chat, and we also have a QR code at the end of it. So we have no relevant disclosures from anyone on the panel or the reviewing committee. And so what we're going to do today is really take you through two main areas of updates. For one, the statewide standing orders for undesignated albuterol, as well as opioid rescue medications, mainly Narcan, in our schools. Then we're going to dive into some of the couple of new components of the Certificate of Child Health exam form, also go into some immunization considerations, and help you identify how to really implement the new components of the Child Health Certificate of Child Health exam form with the appropriate screening tools. And then we're going to close out with updates on the expanded lead screening and how that will impact your clinical care and decision making for your patients. So with that, so let's really talk about undesignated albuterol and opioid. Why is there a need for this? So you think, okay, if a child has asthma, they should have their rescue inhaler with them at all times. It turns out that sometimes they don't, they forget, and it's also not enough. And there were over 1,200 asthma-related calls to 911 from schools in 23. And so the Illinois School Code actually allows for undesignated albuterol as well as opioid agonists. And we're going to go into the opioid agonists in a bit later in this discussion. There are also epinephrine and glucagon. We're not going to focus on that during our discussion today. So we're really going to focus our information really on opioids, opioid antagonists, and albuterol. So for awareness, an undesignated medication means there is no prescription or prescribed individual associated with that course of medication. So in February of 24, we launched put into effect our first statewide standing order for albuterol. And part of this was to address the need that some school districts don't always have a medical director who can provide a local standing order or a local protocol for that school district. And so to bridge that gap, we're hoping that this will help some of the schools that have not been able to tap into that resource. This really has the requirements for the training and the references to the school code that must be really followed in order to function under the standing order, but also a little bit of the clinical protocol. And you can, under this, use your inhaler on a child that has asthma or is in need, up to 3 times. But please know that, at no point in time does this preclude you from really seeking additional emergency services if you feel that they're not responding. You don't necessarily have to wait for that, total of the 3rd dose to make a decision about whether the child needs any emergency services. And let's go a little bit into what really is required to function under this protocol. So one, most recently, both the public, charter, non-public schools are required to keep a supply of an opioid antagonist, mostly naloxone. There's nalmefene that's new on the market too. Now, it authorizes, but does not require schools to stock undesignated epinephrine or albuterol. So just remember, it requires opioid antagonists, but so there are maybe several schools that don't have undesignated epinephrine, don't have undesignated albuterol, and schools are also not required to have a school nurse or trained personnel who can do this, which means if you have or you work with a school that doesn't have this, that might be a challenge because they really won't be able to function under this protocol. So if you do want to function on this protocol, you really need to make sure you have trained personnel. It doesn't have to be only a school nurse who is really able to act under this protocol. This might seem like a no-brainer. It should be, the protocol should be near the emergency medications, or any standing order should be near where the medications are actually located. If you need to know when, say if it's a large sporting event, that these medications will be available to the people attending and where they will be located. They're stored appropriately. It gets very hot, gets very cold. So it's it's important to make sure that storage requirements are met, and that there's a notification process for both EMS as well as the Illinois State Board of Education. Now, the protocol does require there's notification of the prescriber, since the prescriber is Dr. Vora, director of our agency, and also a pediatrician himself. We really get this indirectly through the reporting through the Illinois State Board of Education. So how do you train your personnel? Sure, they're CPR and AED trained. Again, they know how to access the medications, that they know how they're going to be notified, what's the equivalent of their code blue, so to speak, how to administer it, and all the other escalation emergency protocols. Now, parental notification, school needs to notify that they have they were functioning under these protocols, and the guardian has to acknowledge it. Now, there used to be a time where parents could opt out of rescue medications, and thanks to the work of our former pediatric advisor, Dr. Quinlan, and the State Board of Health and the State Board of Education, they actually have changed the code now, so a parent no longer has the option to really opt out of rescue medications, because it'll be very challenging for someone in an emergency situation to determine that, oh my, this child is unconscious, is turning blue. Did this parent opt out of rescue medications or not? And I don't think it's a decision we want our emergency responders and our first line responders to have to try to make, or the knowledge that they have to try to seek at that point in time. So what more have we done in Illinois besides try to issue a standing order for this? So there is a Rescue Illinois program that we've initiated through the Asthma and Allergy Foundation of America, as well as the Respiratory Health Association. A lot of this data in the next few slides is from the RHA. And what they do is they conduct the trainings that are required to get you up to speed, as well as provide free stock albuterol. So it's really at no cost in a program for schools who want to participate. And they've done trainings, over 2,000 trainings for our school nurses, but teachers too, athletic staff, clerks, principals, superintendents. And in the first year of operation, out of 3,000 eligible schools, about 1,200 signed up. Hopefully that number will get higher in the years to come. And of course, they have a handbook how to use stock albuterol. So that's also something that schools, even if they don't necessarily want to sign up for this program, still have access. So why is this important? So this is how they looked at what's happening in schools. So, there are over 500 reports of an emergency albuterol being used in schools over 33 counties. We know springtime is a big, as I said, a hot point for children having asthma attacks. On the right side, you will see the map of the per capita asthma ED visits by county. Now, this is slightly old data, but you can see the counties, the dark red are where you have really high rates of children in that county going in for asthma visits. And then you see in the dots how often have has albuterol, stock albuterol been used in schools? And I think that if you are working in a county that is really deep dark red or dark red and you're not seeing any stock albuterol being used in that school, the question is why? And do all the schools have it? These children have need. Is that need being met? Are we able to close the gap? And I think that's something I'd like you to take back to the communities that you work with and see if there's something you can do. So this is not just lip service. This really makes a difference. So this is, again, from the RHA through the Rescue Illinois program. And they looked at the number of children that actually received stock albuterol or emergency rescue asthma medications. And 77% of them were able to go back to class. And that's what we want. We want our children to be able to stay in class, not have to be sent home. A few had to be sent home, about 20%, and very small percent, less than 1%, actually needed to still be sent to the emergency room. So, one of our local health departments, Lake County, just put out their report. They don't have, not necessarily the Rescue Illinois, but they have their own undesignated albuterol, undesignated medication program. About 30% of the schools signed up in Lake County, and in sort of a 1-year time frame, they had about 13 events in the schools that signed up, where they could track what happened. And the good news is, out of those 13, mostly it was asthma related. 911 was only called 3 times, and there was 100% successful recovery of all the children. So this really makes a difference. In fact, if you don't have these emergency medications, the projections are completely flipped, that the kids are not going to go back to the classroom. Most are either going to be sent home, or about 20% will end up going to the hospital in an ambulance or having EMS transport. And so there is really not just a clinical, but a cost argument. I mean, the missed work, the missed schools, the cost of clinical care, all of that is significant. So hopefully people will be able to advocate to their school districts to think about these protocols and sign up for them and consider what they need to do to function under the standing order. So in addition, IDPH has also developed an asthma caregivers handbook. It's a big handbook, but it's very simple, easy, 6th grade reading level. You can download it. It's open access. I put the link on there. And just a glimpse of what the contents are. So there is, again, to see your how the parent can really manage asthma. How can they talk to their child about asthma? Think about their asthma action plan, treatment, several things, again, that are tips, self-care for the caregivers, whether it's daycare, school, college, adulthood. Again, apologize for a bit of the blurred graphic there, but just to give you a glimpse of what is really being discussed here. So let's talk about opioids, right? We all think, well, okay, albuterol, kids have asthma. My kid does not use or will never be in contact or never be exposed to any opiate unless it's unless it's like a prescription or they need it. Unfortunately, that's not what we're seeing. So just in 2024 alone, and we're not even, we just past the halfway mark in 24, there were over 900 suspected overdose calls, and 300 of those from schools, and 300 of those actually required Narcan. And so when you look at it, this is the CDC national data, not specific to Illinois on the right side. 15% of high school students have used illicit drugs. Injection drug use is also more concerning, not just from the substance use standpoint, but also from the infection exposure, infectious disease exposure standpoint with HIV and Hep C. 14% of our kids in high school reported misusing prescription opioids. And unfortunately, this is, I think, an important thing to know. When our children are going to be engaged with either prescription opioid misuse or any substance use, it really consequently exposes them to high-risk sexual behavior. sometimes transactional sex to be able to obtain these. And again, it's more likely that they've also been a victim of physical and sexual dating violence. So it's important when you think about this to also think about what's going on with the whole child as their mental state of mind and what is really potentially driving them. And I think CDC has also put together a list of what are the risk factors that trigger some of this and what are the things that are protective factors. And I think it's good for us as providers, as parents, as members of the community to just be aware that yes, family history counts, but I think favorable parental attitudes have been shown to also prompt behavior that includes, again, prescription drug, opioid misuse, uh, for parental monitoring. And I think this one's a really important lack of school connectedness. Kids who are feeling isolated, even their own past traumatic ACEs or adverse childhood events can be really a trigger for this. And so it's really important in this world where we're so digitized to understand that just that sense of isolation can be a risk factor for children to have some of these risk behaviors. Similarly, the opposite is true in terms of what is found to be protective. Family support, engagement, again, parental disapproval of substance use. So not saying, oh yeah, sure, it's okay, it's just a little bit of cocaine, don't worry about it. Parental monitoring and also school connectedness. And so I think this is, again, something for us to think about, not just as providers and health professionals, but also as members of the community at large. So what did we do about this? We've had a statewide standing order for Narcan specifically for a while, for years now. We added nalmefene, which is considered to be potentially better against fentanyl-related overdoses. So nalmefene is also included in there. And we have just most recently in this past year included schools as something called a naloxone entity, where an entity that can now dispense and administer Narcan by trained personnel. Again, the same training requirements apply. So we're going to pivot a little bit now from rescue to prevention. So we mentioned that we're going to give you a little bit about school immunization updates. So here is something about the school vaccine dashboard. So we have a new dashboard here to have people just be able to walk through what's going on in their school districts with their all the required school vaccinations, right? So I put the link in there. Please start exploring this dashboard for the schools in your area to get a sense of, as a provider, as a health professional, what is it that you might be dealing with in terms of vaccination rates or herd immunity in your community. So this is why this is important now. We're really seeing disturbing rates. For the first time in years, we've gone below the 95% sort of protected herd immunity threshold for Haemophilus influenza, pneumococcal vaccinations, and Tdap. We recently just got notified last week about a pertussis outbreak, and the provider that was servicing these children who were involved is someone who has very low vaccination rates for the community they service, and unfortunately also seems to encourage religious exemptions. Has put up a listing of ways of obtaining exemptions. And I think I would encourage people, you are the trusted messengers for your patients. They believe you, they know, they trust you. I'm hoping people on this call understand why vaccinations are important. If not, we're happy to have much more bigger, deeper dives into this issue. And so I just want to highlight that it's unfortunately downtrending. It's almost touching like the 96%. Hopefully we'll be able to reverse the trend, but this is a call to arms for all of us. We have to do something to reverse the trend of these downtrending school vaccination rates. It's not safe for our children anymore. And I think there are tremendous implications, again, for our society and also as they get older. So we did issue a survey to our school nurses to try to figure out what's going on. Is it so hard for our children to be getting vaccinated? And some of the answers were very, again, concerning. But the providers are the one who who have to sign off on religious exemptions as well as medical exemptions. But apparently even we're not making it clear even what the validity of the medical exemption is. And I think we really need to ask ourselves, is this truly a valid medical exemption? Our school nurses are having a hard time determining the validity of religious exemptions. McKinney-Vento is for unstably housed children, and the challenge is we don't necessarily check 6 months or a year later, are you still unstably housed? Does this exemption still need to apply to you? And here's you could see there's one that challenges the healthcare provider not completing or signing a religious exemption form. This is more from a parent not feeling like they need to get a medical provider to sign the religious exemption form. They just get it from a faith leader. Um, but we also try to get it, what's the barrier to getting a timely vaccine? And this is a multiple choice question, but healthcare provider barriers really were up there. So we're part of the problem here. At least let's fix our part. Let's fix the part that we're in control of in terms of making sure vaccine access is available. Please make sure that if you have students who are indigent, that you've signed up either for our VFC program so that you can get them free vaccines through the state. And there's no cost implication to you or the family. And again, lack of provider awareness of the minimum requirements for the school code. This is disturbing. We should know what the school code requirements are, but even looking at the answers, so many times it came up that the providers say, oh, we're going to follow CDC. But CDC is not the Illinois school code. CDC doesn't, they have recommendations, but we have requirements. So there are requirements. You have to follow the Illinois school code, not necessarily the CDC requirements. There were also some disturbing feedback how when school nurses are spending so much time and energy trying to track down, get vaccine records, get the appropriate information, that providers are not necessarily very responsive or very receptive, and have even tried to say, oh, I'm the doctor, you're just a nurse. I think that is unacceptable. We really need to work with our school nurses and our school system to give them the records that are needed, to be able to have a sense of what's going on here. And just so again, if anyone on the call was not aware of what our school code vaccination requirements are, here they are. The link is in here. I just put the first one. This is how it's structured. This is the Illinois updated 24-25 minimum immunization requirements. And with that, I'm going to turn it over to Miranda Scott, who leads our school-based centers.
Thank you, Artie. So I just wanted to do some broad strokes and give everybody some information about the Child and Student Health Examination and Immunization Form. I think many of you are quite familiar with this form, but if you're not, just to give some broad strokes, this form is utilized when a child first enters school in Illinois, which would include nursery school, special education, Head Start, other pre-K programs, or when a student first comes into Illinois outside from the state or the country. This form is also utilized if they enter kindergarten or fourth grade, if that's their first entry into Illinois school, or entering into sixth grade or ninth grade. So those are the timeframes that we have those forms to be required to be filled out and sent to the schools for review. Where can we get these forms? The form can be accessed into iCare. It is built out in iCare, both the Spanish and English version. You can also find it on the IDPH School Health Program homepage. We have both versions on the homepage that are PDF fillable. The Illinois State Board of Education School Nursing homepage also has links to the form, and you might receive it in paper version from schools because they make packets, registration packets that they give to families, and the families will bring it into you directly. So more about the updates. This form was recently updated and posted on the IDPH School Health Program website in January 2024. We sent out a lot of notices, email blasts, sirens to let people know that the form was new and had some updates. Because the Child Health Exam Code allows for an exam to be provided 1 year prior to school entry, we request that providers and schools utilize the new form before January 1 of 2025. The older version of the form can be accepted until January 1 of 2025, and we kind of notated this. So we're basically giving a 1-year kind of transition period just so that we don't have forms going back and have undue requirements on parents and providers, so that everybody is aware of this transition period. So what we'll do is we'll take a look at some of the new changes that are now on the form. And we can go to the next slide, please. In the old version of the form, the healthcare provider would fill out the required components of the exam performed. And historically, that portion was at the top. Please note, though, this has now been changed. So the top of the form, the parent guardian portion of the health history was moved to the top of page 1, and we have a little arrow pointing to that portion. We did this because it was based on feedback from clinicians stating that this portion was often overlooked by families. Moving this portion to the top allows school nurses and clinicians to ensure the parent guardian has completed and signed this section. And the confusion does lie because the health history looks very similar to the exam portion that's filled out by providers. So we really wanted to draw this out and explain to people this has been a change. Please note also in this parent guardian section, another space was added for additional information for parents or guardians to provide, which could be anything that they feel is relevant that might not be covered in the parent health history. This section, again, is only for parent or guardians to fill out and sign. The provider is not required to sign this section. Next slide, please. The immunization portion of the form was moved to the bottom of page 1. So this section looks exactly the same as it had before. It just moved down under the health history. The bottom of the page requires a signature of the provider, nurse, health official of that individual who provides the immunization history. This requirement has not changed. So whoever does sign off on those immunization portions can sign here. Now, if you as a provider wants to sign off on any new immunization pieces, or if your office nurse pulls up that health history, they can sign this here. It does not matter if it's you or the nurse, or even if a local health department signs off on it with their health history, but someone must sign off on the immunization history. The section again has only moved on the front page of this form. Just to also note, if you are looking to figure out what version of the form you have, if it's the older or newer, the first page contains a date stamp of the 12/23 date. I know on this slide it's a little bit hard to see, but it's at the bottom of the first page. This allows a provider to know what version of the form they have. The older version of the form is date stamped 11 of 2015 on the bottom. So much difference in the years and the dates there. So next slide, please. The proof of immunity section now begins at the top of page 2. So if you think about this, it's much more streamlined, where the provider on page 2 is doing all of the work here. So the physical exam requirements are here. Screening requirements for providers are all on page 2. Very simply, you can go to that page and look at that. Of course, you should always review not only the immunization history, but the parent health history on the page 1. But I think it makes more sense now, where we have on page 2 a lot of the information where we're looking at all the exam and screening requirements for a provider. Updates on the form were required to align with the new Administrative Code 664. And this administrative code requires, too, that developmental and social emotional screening, if it was provided, then a date of the screening would be provided on the form. I have this highlighted in that circle there. I know it's sometimes hard to see, but please note that only you'll see boxes that say date and results. The admin code 664 does not require the results to be placed in the box. So what they're asking for this section is just a date if it's completed, and the result says completed or NA. What does that mean? Well, if you have a documentation from a mental health provider or another entity that provided the screening, you can date and hit mark completed if you want. The code does not prohibit students from attending school if these screenings are not performed by the provider. However, we know that many providers are performing these screenings, and so it's really good for them to actually provide those results in that it was completed as a result, the date and the time, or I'm sorry, the date and that it was completed on the form. However, again, I want to stress that if another provider has screened this child and you have those results, you can definitely enter that on the exam. The bottom of page 2 also contains the area where the provider signs and dates the exam form. And so if you think about it, previously it was on page 1. This has been a little bit of confusion for providers. So please note this is where you print and date or use your stamp or have your EHR system do an electronic signature. Next slide. So how do we screen? What do we use? Many questions. The admin code did require IDPH to provide some tools on our website, and you will find that here. It's on the IDPH School Health Program homepage. Please note this list is constantly evolving. Anyone may ask to have a screening tool added to the list. There are certain requirements if you want a tool to be reviewed, and it's on the IDPH School Health Program homepage. However, if you want a tool to be added, you may definitely email us about the process, about any questions about the tools that are currently there, who can actually screen. Now, please note that the code does allow, if you do not put any developmental screening or social emotional screening results on the actual form, a school may be allowed to do that screening in the school. I also caution those individuals that schools sometimes will do their own screenings, which are different than these type of screenings, which include like social emotional learning, which is more encompassing of the school environment. So I think there's some confusion there of, hey, if the school did it, what do I have to do, or vice versa. And so I think this portion was more to encourage providers to start looking at social emotional screening and developmental screening for all students and patients. And for that, we can move to the next slide, and I will hand off to our next presenter.
Hi, yes, so I just have a brief update on lead. As a reminder, there is no safe lead level. Lead can have serious and long-lasting effects on child health, and the most common source of lead poisoning remains lead paint in older homes. And to that end, there is a move towards universal lead testing by 2026. So expanded lead testing will ensure that more children have access to early detection of elevated blood lead levels, providing the opportunity to remove those harmful exposures to lead and help Illinois children grow up healthy and lead-free. Next slide, please. So recently, this was announced at the beginning of July, there were an additional 148 zip codes added to the list of high-risk zip codes. So these were spread across 60 Illinois counties and total about 1,200 high-risk zip codes. So there's a link here, and the QR code goes to that link of listing the high-risk zip codes. These are additional zip codes in which children should be screened by blood lead testing. So the addition of these high-risk zip codes helps advance our state closer to a couple of different goals. One is implementation of a public health intervention of 3.5 micrograms per deciliter. This is recommended by the CDC. So sometimes people think about what a quote unquote normal lead level is. There is no normal lead level, and the blood lead reference value has been decreased over time as we've made amazing public health strides to reduce lead toxicity and remove exposure as much as possible. So recently, in the last couple of years, there was a recommendation from the CDC to move that blood lead reference value and the level for public health intervention from 5 micrograms per deciliter down to 3.5. There are a lot of pieces and parts to making that happen, and increasing the counties or the zip codes in which children are high risk will help us move towards implementation of that decreased level. With that decreased level, there are more children that will be identified as having an elevated lead level. Increasing these, or the new addition of these zip codes will also help move us towards the goal of universal lead testing by 2026. And universal lead testing will help simplify screening requirements and ensure that all children are screened and receive risk mitigation. This is something that's being done in other states, 16 other states so far, including neighboring states of Wisconsin and Iowa, as well as a number of other states. Next slide, please. So as a reminder, lead screening is required for entry to daycare, preschool, kindergarten, and other childcare facilities and should be documented on the child health certificate. Children should be screened at 12 and 24 months. And for those who live in a high-risk zip code or are covered by Medicaid, they should by default be screened by blood lead level testing. And so that's why it's important to be familiar with those zip codes where children are at risk and recognizing that there are new zip codes added. So new families may need to be included in that screening. Children who are not covered by Medicaid or do not reside in those high-risk zip codes fall into that lower risk area, and they should be still screened by the lead risk assessment questionnaire. And if they have risk factors identified on the risk assessment, should be screened by blood lead level. So that's just the update about blood lead, to say that we're moving towards universal screening, and there were recent new zip codes added that that imply families and children, residing in those areas that need blood lead screening. Next slide, and I'll hand it back to Dr. Barnes.
Yeah, and these are just some resources that we have here that Miranda has put together too for us. Again, we have these live embedded links here. Hopefully that will be helpful for our clinical community to be able to access these fast and know where to go to for information. In addition, you can also, if you have questions, reach out to us. There's this Smartsheet form. It's like saying, what kind of question do you have? Our medical advisor team can help answer that. And finally, what's next to come in our Fast Fact series? So in the next, if you've not heard of diamond shrooms, here's your opportunity. And rhinotrank, basically we're going to focus on xylazine, metadormidine, and some of the new street drugs that are really complicating opioid overdoses. After that, we're really focusing in October on the respiratory season and how all the considerations that we need to think about as providers, all the way from prevention, testing, vaccinations, going into the respiratory season. And in November, we're going to really give you an update on sexual reproductive health. We have a birth control, a contraception standing order, which I think will be important for people to be aware about, as well as, again, our HIV PrEP programs that it's called PrEP for Illinois, and our congenital syphilis initiative. So sign up and please register if you're interested in any or all of these topics. And with that, please note that if you can scan this or use the chat to just answer the questions and get CMEs. And again, if you have any questions, you can also reach out to Stephanie at Ella at Illinois AAP. That I'm going to close this. Again, I'll give it maybe 1 minute if people want to scan the QR code instead of using the chat. And then once I stop sharing, I'll be able to access the chat too.
Stephanie, from ICAP, could you go over again how the slides will be distributed and so forth? I think we weren't quite recording and some people might have joined late. That's one of our early questions. Will they receive slides?
Sure, Doctor. That's something that we're not managed. This is on the IDPH WebEx, so you all have access to the registrant. So I believe David's taking care of recording and we'll be sending out the slides. And we're just helping with the CME portion.
Yes, and I think David will send out the slides to all the registrants. So not just those who had a chance to attend today. All right, so let's try to go over again. If our panelists want to come on camera, we can see what questions we have in the chat that haven't been answered. If you also would like to ask questions live, raise your hand or your virtual hand, so to speak, and we will try to get to you. There are over 200 participants, so don't all speak at once. So again, just raise your hands and we'll get to you. So does, I see, does I believe Dr. Cunard, you answered this one. Does IDPH have plans to provide a statewide standing order and prescription for undesignated epinephrine? Yes, so we are working. It takes us a while to go through the legal procedural processes to develop a standing order, but that is definitely something that is being considered right now. It won't happen immediately, but it's in the works. Yeah, and you'll receive a copy of the slides. Could you have
I can
once
take
you've
this
gone
next
through?
question about the opt-out question.
Yes.
Okay, please clarify the opt-out for undesignated meds. The current code does allow for parents to opt out of the administration of these medications. However, in an emergency rule, ISB has proposed to change that. It has gone through the JCAR process and went yesterday, is my understanding, to the State Board of Education for a vote. Our anticipation is that as of January 2025, that will go into effect. But it has not been completely finalized yet, but we're just giving you a heads up that that's the anticipation that schools will be allowed to administer life-saving medications during an emergency, and parents will not be given the opportunity to opt out.
As far as the question about how often do you have to take the Rescue Illinois training? I'm not sure. Miranda, do you know how often they might have to take the Rescue Illinois training?
I am not sure, but just to, we could also ask ISB because there are requirements for the school code for undesignated medications and how often that training needs to be completed. So Rescue has graciously provided the free education for that component for the school code. So that requirement would be under the school code, and then Rescue can provide that training whenever it is needed.
And is there grant funding to pay for the undesignated emergency medications? So if you sign up with Rescue Illinois, they will be able to provide it. Now, they will prioritize schools based on, I think, the schools, vulnerability, demand, all of that. So they do have prioritization process, but you can get it through the Rescue Illinois program. Anything to add to that, Miranda?
One resource I have given to some schools, our ISB partners have a link for free epi injectors for schools only, and it's a program through the actual pharmaceutical company. I've heard there were some delays getting the supplies, but it is free. So if you want to reach out to me, I can definitely send you the link of where to access that. And as for the opioid reversal agents, we've heard a lot of individuals going to local health departments or other entities that can provide that to you free of charge. So that's another option, or you can purchase, or your school district could purchase it from a pharmacy. However, again, that would have a cost.
Great. And I think we have a thing about CPR requirements for opioid antagonists. We're not aware of removing. Yeah, go ahead.
Yeah, I did put in a link to the school code, and it does require that you're trained to do rescue breathing and resuscitation. So as part of responding to an opioid overdose. But you can certainly talk to your legal. We're not lawyers here, but that is in the code.
We have another question. Can we not sign off on paperwork if parent is asking us to sign off on? We educated parent, given the BIS for vaccines. They still don't want vaccines. I don't want to lose the patient, so I sign the forms, although I don't agree with the parent choice. So, you're right. You cannot, you have just make a judgment. You don't want to compromise your relationship with this parent and the child, because the hope is down the line you might be able to convince them otherwise, and once they build a trusted relationship with you. I think if there are a lot of talking points CDC has also come up with, if you need talking points, especially around specific things like H influenza, why is this vaccine important? Not, beyond that, things that will help you have those conversations with your parents, with your patients, just let us know. And LaDarryl, do you have anything to add on that?
Nothing on my end.
Okay, great. All right, what else? So Dr. Chug, so asthma handbook looks great. The what proportion of persons receiving undesignated albuterol are without an asthma other diagnosis? We don't necessarily have that information. I don't know if ISB collects that information. And how we do know that often these are actually, Lake County Health Department, their report did collect that information, and I think I cannot recall, but there were a portion that had a known diagnosis of asthma still, and a portion that didn't. For things like epinephrine, often from what I recall of the literature, about 25% of those attacks happen for the first time in the school without any preceding event that would prime you to knowing that you're going to have an anaphylactic reaction to a certain exposure. All right. And how maybe prevent temporary relief in school with potential recurrence of symptoms in a setting like a home store where a parent may not be present? I don't know, Dr. Chuk, do you want to expound on that a little more? What you mean by prevent temporary relief in school?
Are you able to come off mute, Dr.
I-
Chu?
Yeah,
Also,
don't
I
seem
wanted to
get,
mention
unmute.
that each year ISB provides to the legislature a report on the use of rescue medications, and I just checked their asthma report, and it does include how many kids had not had a prior diagnosis.
Great.
It's on their website. I'll put a link to where those reports are.
Thank you. And Lisa, I cannot tell. Lisa Kilawi, have you raised your hand? If yes, we can try to get you off mute.
Yeah, I just had a question. I put it in the chat too. We're trying to decide. So Bright Futures is still required. Does Bright Futures count as a developmental and a social emotional screening tool? It describes itself as such, but it's not on your website as a tool. So I wanted to ask.
So that's a great question. Our tools are definitely in evolution. So we have looked at that. We actually have had other requests to add. And Bright Futures is all encompassing. It has many, many different portions. One area that might be helpful too is we use the periodic screening schedule that's actually in combination with AAP and Bright Futures. So that was one link that was on there too that kind of gives recommendations on screening for social, emotional, and developmental. So in the broad strokes, I would say yes, as long as those tools are all encompassing, but you can definitely email that request for that addition to us because we looked at many, many different tools, and not to say it's an all-encompassing list that we have now. So we're all open to that.
Okay, thanks, because it would just be a lot to do Bright Futures and then 2 more screening tools.
Right. And Bright Future, and there's nothing wrong with doing something more than less. I think the concern was we had so many tools that are out there and they may not fulfill both. As you can see, we have some that are just developmental, some that are just social and emotional, some that you have to pay for, some that are free. So we wanted to make sure we had at least a starter list of things that would be really good. So yes.
Great. Great. So Dr. Chug, I think, did you want to come off mute?
Yes, thank you. Yeah, my question was about the, like I said, I think the handbook looks excellent, a nice way to plug, parent and child into better care and management if their diagnosed asthma is not being proactively or well managed. But in, say, children who are undiagnosed and, are eligible for receipt of the undesignated albuterol and then receive temporary relief and don't receive care, either through EMS or elsewhere, how do we know that they're not recurring at a later time when they're not in a school setting? And for example, we don't want people self-treating with Primatene Mist or something if they're not otherwise evaluated and receiving appropriate management. So just wondering if there's a way to track outcomes following administration for those who have not been diagnosed with asthma. Thank you. And the other point I was going to mention is I agree that with the emergency or undesignated epinephrine administration, that does often occur, or the instances occur often in persons without a previous diagnosis, but at least in our protocol, we routinely do have the schools contact EMS in addition to the administration of epinephrine. So they are receiving that additional follow-up.
Yeah.
Thanks.
And again, I think, in terms of what our surveillance authority is also limited for what the things we can, how far we can go in terms of obtaining information about people's health. Perhaps a survey or something that might, for those who received it, might help in the future. But hopefully the schools and SB, can have some form of communicating with the parent about what happened, what occurred, that, hey, your child needed albuterol for the first time if they've never had an asthma diagnosis. Hopefully now, with awareness that this kind of handbook exists, provide them that information, and they can have their healthcare provider try to address some of those gaps.
So maybe for those who don't receive the asthma handbook, to still follow up with their PCP or, their child's provider.
Right.
Got it.
That would be an important thing.
Thank you.
So, all right, I'm going to try to get through all these. We have 8 minutes left in all these questions. What we will do is, if we cannot get through all the questions, and please, panelists, start answering questions in chat if you can, so we can try to get through
I
that.
just wanted to mention, I did put those links into that annual report, and it looks like about 20% of the people who had received asthma rescue medications did not have, out of 300 and some, did not have prior diagnosis.
Yeah.
So you can go to that page.
Great, thank you. Maybe Ladara, do you want to take this? Can school staff sign permission forms for students who are MV, I'm assuming McKinney-Vento, and need immunizations or a physical? Assuming the question is, does it have to be a provider, or is it like a non-medical provider who can sign off on these forms? I don't know if Miranda or Ladara, either of you.
Yeah, I'm wondering if I'm trying to gain understanding of the question too, that I think the McKinney-Vento, I'm trying to figure out if they're saying that they cannot find or get with the guardian of the McKinney-Vento student to get permission for something. I'm trying to figure this out. I know there's been a lot of questions about McKinney-Vento and how that works. And each school district has a McKinney-Vento liaison that works with the schools. I'm just trying to figure out, kind of clarifying that question a bit.
Yeah, I'm not. Again, if you want to come off mute and just clarify that. And I think in the meantime, Dr. Spencer, there's some questions about the lead in the chat too, if you could try taking those.
I think Kurt answered the one about cap versus venous stick. That's the only one that I saw.
Okay, and I think there was
lead risk zip codes. Okay.
Yeah, and any recommendation which lead testing? Okay, all right. So hopefully Brooke can answer those questions in chat. I see a question on IM penicillin. So it should be commercially available. There used to be a shortage. From what we've been informed recently, that shortage is no longer exists for IM penicillin. If you want to send us an Linda, if you want to, I'll put my email in the chat. Send me, or put in, we'll connect you to our STI program, and they can see if there's a service provider that has some IM penicillin if you're looking for free, but in theory, it's no longer in shortage, so you should be able to commercially get it, have it commercially available. Right. So let's see. piggyback parental refusal to vaccine. What to do when kids are attending school? Is this something reportable? Wonder about the other children who may not be vaccinated because of other reasons and potential exposure. So, Daryl or
What was that question again? I apologize, Dr. Barnes.
sorry. What do we do when kids are attending, unvaccinated kids are attending school? Is this something reportable? Wonder about other children who may not be vaccinated because other reasons and potential exposure.
It all depends upon the reason that they're not receiving vaccination. Is it through, are they doing through exemption, or they're just choosing not? Because if that's, then they can be excluded for not being in compliance with the immunization requirements. So it's a little, I don't know why the child is not being vaccinated, or why they're not receiving those vaccines.
Do you have a contact that those individuals could reach out to if they have a question to discuss the nuances, Latero?
Yeah, I put something in the chat. I put a coach level email address in the chat for that.
And to piggyback off of that, schools are required to have an exclusion policy. So if there is an outbreak in their school, there should be a policy that those parents are aware of. And another piece that also adds, because that's, you know, based on district and school level. So there should be policies in place, and they should have a list of who are not vaccinated as well.
Dr. Barnes, I was going to just
Yeah.
add to that because we've heard from a lot of our school nurses and providers that the exclusion criteria is actually not being enforced by the school leadership. And so that it is on the school to enforce that. And oftentimes they're almost incentivized not to because the school head count of attendance it is related to funding. And so I know at the chapter we're working on, we sent an email or an email and a letter to all the superintendents, encouraging them to encourage the principals to please enforce the school requirements in light of the measles outbreak that we experienced in the Chicagoland area earlier. And so that's at least something that we're aware of because we know some of our pediatricians and school nurses are very frustrated because the rule's only as good as it's enforced. And as Ladero said, students who are exposed and are not immunized should be excluded from school for 21 days in most cases. And parents should be made aware of that prior to the school year starting so that they may be incentivized to not have their child out of school for 21 days should there be an exposure and outbreak at the school. So.
Yeah, and again, reportable illnesses, if you've put all your, if you're an eye care provider or even VFC provider, then all your immunizations will be in the system so we can see which child has been or not been immunized and what they've not been immunized for in a way. Sometimes, again, it's not complete. Not all providers report their vaccinations into our eye care system. I think we have one last question because we're down to time. And then Illinois exclusion is only for religious reasons. Do parents have to provide what religion it is? And most world religions don't oppose vaccines. All right. Daryl, do you want to try to take this one?
I might first say there is a religious exemption form that must be filled out by the parents. This is one thing I must tell everyone. The providers are not there to sign the form to state that they agree with the religious exemption. They're just signing, explaining they have talked with the parents, the guardians, and letting them know about the risks of not vaccinating. It is up to the local school authority to determine if those religious exemptions are valid. I think that's where a lot of providers are hesitating. So just please note that goes back to the local school district and for them to make that determination. And I don't know if Ladero has any other thoughts on that.
Just piggybacking off what you said about that, because we usually do around this time as schools get started, we receive questions about compliance if students are in compliance with this religious exemption, and we do not. We have no authority over that. That does go back to the district, and that goes to what Stephanie had said earlier, is if they are looking into that and they are enforcing those religious exemptions when they are presented to them, because we have no authority of it when we do receive those.
I see one question in the chat too. Madonna, did we get to you, Pifan? If not, please come off mute. Madonna, do you want to ask a question or? Oh, I sent a clarification. All right. Are there plans to eliminate religious exemptions in Illinois? That's a good question. More to cover that in the future. So I think, yes, there are other states that have gone that direction. And you're right, most world religions don't have an opposition to vaccine, and if there are certain vaccine products that they have like a, say, pork gelatin or something, there have also been statements that have been by main faith leaders that have said you can still get the vaccine because it's been processed in a way that shouldn't really contaminate or spiritually contaminate your system with those components of the vaccine. So it's a it's a difficult as I said, concept for a lot of people to handle. But providers just have to attest that they've educated them. They don't have to attest on the validity of the religious exemption. All right. Thank you. Thank you very much. We appreciate everyone spending their lunch hour with us. Hopefully we'll see you again next month for our next Fast Fact session. Take care. Bye.